Yeah, Shine. Thank you very much. And first off, I just want to thank all of you for like having me here. I think the purpose of all this is really comes down to mentorship, and hopefully we'll talk about that a lot today. But I think mentorship, and there's from an early stage, from high school to college, through med school and residency, and even beyond, even up to this point, I'm still mentored. I have mentors. I think it's such a vital part of kind of having this health professional route, whether it's kind of physician, nursing school, PAs, NPs. I think, that's such a vital part of it. So, programs like this, I think, are fantastic for creating these venues to connect with mentors and advisees. So a little bit about myself. So I grew up in North Carolina, outside of Raleigh. So Cary, North Carolina is where I grew up. Did all my kind of high school and schooling there. Went to college at Chapel Hill, and um, ended up in going to medical school outside the country, and we can talk about a little bit about that and what that path was like. And then finished up my clinical rotations. So basically, medical school for most part, traditional medical school is the first half, 2 years, basic sciences, so a lot more book work and kind of studying tests, and then the last 2 years are more clinical, where you actually see more patients and learn kind of uh, practice the things that you've already started to learn your first 2 years. And then after medical school, did my residency at East Carolina University in Greenville, North Carolina. And around that time, and I think another big part of becoming a health professional is the life outside of medicine, right? And I think I want us to talk about those things too, because it's important to find ways to kind of cherish your personal life as well. So met my spouse and married her in just right before I started residency. And then not fully planned, but that happens about a lot, actually, 80% of the time. But I had my first child, my first year residency, which by itself was a extreme challenge, and we can talk about that too in depth. But did my 3 years of residency at East Carolina, and then after that, I did a chief year. So I realized I was interested in medical education. And so I did a chief year, which was like a post residency year where I stayed at the residency program as part of the leadership program. And then after that, my spouse and I, she finished. She was also in residency, and she finished. We both finished at the same time, and we moved to Greenville, North Carolina, and that's where we are right now. That was 2015. So 2015 is when we finished training and moved here, and we've been attending physicians since. I'm a inpatient doctor, so I work as a hospitalist, and I see patients in the hospital, and that's how I joined Prisma here in Greenville. And my spouse, she's outpatient internal medicine, so she sees patients in the clinic, primary care in the clinic, and that's kind of where we are. Last, my first 3 years, I did purely clinical work. I was just seeing patients. I was teaching medical students and residents kind of on the wards during that time. And then in 2018, I was very fortunate to be offered a position with the medical school as the clerkship director. So that was the head of internal medicine for the medical school. And I did that for 6 years. I loved it. I loved working with medical students, advising, seeing them match into residency, staying connected. I'm still connected with a lot of the students that I worked with, you know, 8 years ago, and seeing their careers develop. And some of them have become my boss now, which is really cool to see. And then in just this past year, I was kind of transitioned from the medical school to residency, and I'm now the residency program director. And we could talk about what that looks like and what that's about. But it's kind of where we are. I have a second child as well now, a 6-year-old. So I have a 13-year-old boy and a 6-year-old girl. My spouse, she still does outpatient internal medicine. And like Sean said, uh, you know, if you ask me what I do, if some random person asks me what I do, I actually, doctor is not what comes out. I'll say some things like I teach. I like to work with students and learners and residents, and then a lot of the personal things that we love to do. We love to travel, explore different foods, try new hobbies. Those are the things that really are our fuel. And I think you may have heard a lot of things about burnout and wellness and all those things, but I think it's important to kind of keep track of all that at your current stage all the way through your career, because it's easy to kind of forget about those things.
Cool. So yeah, we'll definitely come back to your life outside of medicine. I think that is a someone I look up to, or I look up to you in terms of getting a balance between life and work. So I will definitely come back to that. But to get us started, do you mind kind of talking about what internal medicine is, what kind of patient cases you typically see, the population you work with, and then I guess like inpatient versus outpatient. What does that look like?
Yeah, yeah. So, wow, when I was going through med school, I couldn't really figure out exactly what I liked. I knew I liked to talk to people. I knew I liked to kind of get to know their stories and take care of chronic illnesses. I kind of realized even though OBGYN was my very first rotation and delivering a baby was, such a, amazing moment. I was like, oh, that's exactly what I'm doing. But as I went through, finished medical school, I realized, the kind of chronic illness was where I really was my passion, and adult medicine. So internal medicine really is adult medicine. It's from 18 up until the day that patient passes away. My oldest patient was a 108-year-old woman I saw in the hospital. So you take care of everyone and everything in between. We even help out with pregnant patients with their medical issues, but we're typically not the primary care for those patients. So if I had to define internal medicine, it's really providing that first level care for adults starting at the age of 18. Um, and then, after you do 3 years of internal medicine residency, then you have the option. I think that's another beautiful thing about internal medicine. Another reason I was drawn to it is that you can really go into different career paths with internal medicine. You're not fixed to like you have to be in the operating room or you have to do this. You can go into multiple subspecialties. So I'm sure you all have heard about cardiology, gastroenterology, endocrinology, immunology and allergy medicine, infectious diseases, nephrology, really anything with an ology at the end probably has an internal medicine fellowship. So that essentially a fellowship is additional training beyond your first 3 years of residency. And most of those fellowships, they range, but they're typically 3 to 5 years in length. So as I was going through internal medicine residency, I was also drawn to pulmonary critical care and cardiology, nephrology, and I couldn't pick one because I liked a lot of them. And so my option was to either pick one and just stick with it, or just when I'm done with internal medicine residency, go and start practice. So that was another beautiful thing about internal medicine. It gave me that option and that freedom to choose. Okay, if I really want to continue training and I want to specialize in something that I've really fell in love with, I could do that. Or, if I come to the end of internal medicine residency and I'm like, hey, I'm ready to go and start practicing medicine, I can become an attending physician right away. And then, there's other, I liked a lot of things. So that was one reason I didn't specialize. But, we had a young kid. I was married, family at that time. Additional training just wasn't appealing to me. I was ready to go and start practice. So for that reason, I chose to go straight into inpatient medicine. So inpatient versus outpatient. Inpatient is in the hospital, so taking care of patients when they're admitted to the hospital. So think about patients that come into the emergency department and need to stay in the hospital for several days, or patients that come into clinic and they're so sick that they need to be, taken an ambulance straight to the hospital and stay in the hospital. Those are the patients that I take care of in the hospital as a hospitalist. So I admit them from the emergency room, I take care of them, hopefully get them better and feeling better, and then discharge them home or to a nursing facility, wherever they need to go. So that's inpatient medicine. And then outpatient is similar to what my spouse does. It is what she does. So she's the primary care doctor for a whole host of patients. So patients come to her that have high blood pressure, diabetes, thyroid problems, heart failure, and they get kind of chronic care. So when they're stable and just need regular checkups, refills of medications, if they have minor illnesses, they can be taken care of in the clinic. That's outpatient medicine. When they get too sick for the clinic and they need to be in a hospital, that's inpatient medicine, and that's kind of where I am.
And what would you say would be something that you look forward to every day versus, and then also share something that you kind of maybe not the worst part, but something you find annoying or you don't really like dealing with within internal medicine.
Yeah, I mean that's a good question, and and there are things that are not fun with any job, and I'll try to be as transparent and honest about that with you all. So things I like, as I was in residency and kind of going into my chief resident year, one of the reasons I became a chief resident is because I really enjoyed teaching and advising, like we talked about mentorship. And I kind of didn't realize that going into residency. I was like, I just want to be a doctor. I want to take care of patients and make people feel better. But as I was like, in that kind of system of residency where you're working with medical students and undergraduate students who are shadowing, and residents who are at a lower level and you are just starting, that teaching part was really exciting to me. And ultimately, that's kind of what my path took me. I did my chief year. I came to Greenville, North Carolina, sorry, South Carolina, as an attending, and then continued to teach, and then worked through the medical school. So, for me, my fuel and the part that I enjoy the most about being a doctor is the kind of the interaction with my learners. With the medical students and residents. I love teaching. I love advising. I love those like aha moments because I struggled. There's things that I struggled with understanding, and I tried to really remember, and I try to still remember to this day, like how difficult it is to learn some of these topics and understand them. So when I work with students and residents, I try to be as patient as possible and teach them to help them understand the same way that I needed someone to help me teach, to help me learn some of these topics. So, I think those moments and the learners that are truly interested in being there and learning and gain a lot and give you that feedback, those are the ones I think those are the best moments for me as a physician now. The toughest part, if you asked me this question 6 years ago, I think I would have had a harder time answering the question. But and I think we can. This is hopefully a very safe space, and I want to. I think what's happened in the last 5 or 6 years with medical misinformation and really having to um, take amazing care of your patients who may not believe in the treatments that you're providing, who may not believe in the vaccines that you're recommending, who may not believe anything that you're saying, but you still, in that moment, have to remember that they are very vulnerable and they're sick, and do the best you can to take care of them. And from COVID up until now, I lose patients. I have patients that pass away because of misinformation that's out there. And I don't remember it being like this prior to COVID, and I don't think it was this way. And I think that's a new challenge. That's a new challenge for all of you and for all of us together, is that, how do we connect with people that may not believe in you, may not understand science, don't understand what evidence-based means, and hear something on on Twitter or TikTok or something, or on the media that unfortunately isn't true, but that's what they believe, right? So I think that's the challenge of medicine right now, is how do you connect and love and take care of your patients when, they may not at all believe in the things that you believe in.
And based on your experience so far, like what would you recommend, hopefully when we do go to when we do start practicing, how do we approach something like that? What are some things that you've kind of learned along the way?
Yeah, I think listening is the biggest thing, and we'll break down the case. I have a case that is a very straightforward internal medicine case, but what I've learned more and more is the key to like taking care of a patient is to connect with them and listen to them, understand where they're coming from. Why don't you believe in this vaccine? What do you believe is going to happen, and share kind of your perspective, and ultimately, you may not connect at all, and you just have to be okay with that. I think the times that I struggled, and I may have struggled with this years ago, was when um, I would get upset, right? If a patient didn't understand or didn't agree with me, that I would get upset, and that is the absolute worst thing that can happen, because as soon as I get upset, then that communication absolutely breaks down, that connection breaks down, the trust is gone, and sometimes the patient may even ask for a different doctor, and then you're done. There's no service that you can provide, even though you went in there trying to help that person. Once that trust is gone, they will never listen to you. So always think about, how can you believe that trust? How can you build on it? How can you still find a way to empathize with their beliefs? So I always try to listen and not be judgmental. Be curious, ask them questions, try to show them that you're interested in learning from what they have, and then don't be judgmental in what they say, and ultimately that's the best you can do, and all you can do is do the best you can, And if you walk out that door and you didn't connect and you didn't build that trust, and nothing's changed, take care of the next patient, because there are patients out there that need you, and that you can help, and some of them that no matter how hard you try and how hard you try to build that trust, you just may not be successful, and you just have to be okay with it.
Yeah, definitely. Thank you for sharing. And I think it's really important to realize that you could only do so much. So, I mean, when it doesn't follow through, it's fine to move on and keep trying with the next person.
Yeah.
Um, so you mentioned that teaching is kind of plays a big role in your life. So my understanding is that your chief year played a big part into that. So what is a chief year exactly? How do you go about pursuing it, and what doors does it open up?
Yeah, very good. So, a chief year typically for internal medicine is an extra year after the 3 years. Now, even though it's called chief resident, technically you are an attending physician. You don't get paid like an attending physician, so it is quite a sacrifice. I could have become private hospitalist and made 4 times as much money. But the value of staying in a residency program, teaching, staying in that kind of teaching environment for an additional year, the benefit is that ultimately long term, uh, it shows, and you gain so many kind of teaching skills, communication skills, presentation skills. During that time, you're still in attending on rounds, just like what I do now. So I was with residents and students then, as well as a chief resident. But just taking that, it is a sacrifice, because you can financially do better than doing a chief resident year. But that choice shows others, especially if you're interested in staying in academics long term, that is a commitment you're making. Chief resident is a commitment, is a sacrifice, and a commitment year. So it's certainly, if you have an interest in teaching, and I see a chat already about folks that are interested in teaching, I think that's doing a chief year shows that you're interested, and it also makes you a better teacher, because that is a year spent organizing conferences and lectures, and um, learning how to grade medical student simulation exams, and there's all kinds of things that you can get involved in to really fine tune your teaching skills, and you come out the other end as a better educator. When I came out of my chief year and I started as a hospitalist those 3 years, I didn't think of myself becoming a clerkship director with the medical school or the program director with the residency. But I ended up winning a few teaching awards from the students and residents, and I think those awards were a result of the skills that I gained during my chief year. So you gain skills, and you ultimately gain recognition from those skills, and that's what helps you kind of move into positions like this. Some folks do chief years and then go into fellowship too, so they may take a year and do a chief year, strengthen their application, do more research, things that make their application look stronger, and then go into a more competitive fellowship like cardiology or gastroenterology, something that they may not have been able to do potentially right out of residency. So that extra year gives them, only strengthens their application if they want to go into fellowship. So that's the other option. If you're not interested in kind of going down an academic general internal medicine pathway, you can also apply for fellowship.
Okay. And so that chief year kind of, I guess, ultimately led to you being the residency program director. What does that role look like? And then kind of referring to the question in the chat, how do you balance both of them? And how do both of those roles work in a day-to-day life?
Yeah, yeah. So, as a residency program director, that's a it's a pretty time intensive role. So, our residency program, we have 3 years, 13 residents per year, so 39 internal medicine residents that I help manage. And then with me, I have a great leadership team, which includes 3 associate program directors, 2 chief residents. So we have 2 chief residents in our program, and then 2 administrators as well. So we all together work together to help build curriculum, to build different rotations for the residents. And starting today is every year is recruitment. So recruitment's a big part of our job, which is we get applications for our program. We got almost 1,000 applications for 13 slots. So over the next few weeks, we're going to be reviewing all these applications. Out of those 1,000, we only get to invite about 150 for interview, and we'll do virtual interviews over the next several months. So we'll be interviewing applicants for our program. And then if you've heard of the match, but in March, early March is the match where residents are matched with programs that they interviewed at. So recruitment is a really big part of our time, and I really enjoy it. It's fun. It's fun meeting new people, learning their stories, figuring out why they're interested in Greenville and our program specifically. So that's kind of a big part. So kind of going into that next question was like, how does that affect seeing patients? Yeah. So if I was a full time, when I was a full time hospitalist, seeing patients only, my schedule was 1 week on, 1 week off. So 7 days in a row, I'd be working in the hospital, seeing patients, and then I would have 7 days off. 7 days on, 7 days off, right? So it sounds kind of cool. Oh, you're only working half the year, and it sounds like a good deal. But then you think about it, you're working half the weekends and losing half your weekends, especially when you have a young kid and missing soccer games and things like that, that was starting to get a little bit of a drag. So as much as I love seeing patients, my that particular job was taking a lot of weekends out. So I moved into when I moved into academics with the medical school, I got protected time. So basically, at that time, I was 60% clinical and 40% academic. So I was instead of working 25, 26 weeks a year, I was working like 15 weeks a year. And the rest of the time was, kind of working in the medical school and doing administrative work. The residency program director, which I'm doing now, a little bit more intensive. So I'm getting 60% administrative time and 40% clinical. So I only do 10 weeks, I'm required to do 10 weeks a year of clinical time. So that's a really good question. I think you have to decide if you're getting into academics. You can certainly do as much clinical time as as you're physically able, but once you get into these academic roles, it's really hard. It's impossible to see patients at the same rate that you're seeing them before. So that is a decision you have to make. If you enjoy it enough and you get enough value out of it, then you end up seeing fewer patients. So yeah, I do far less clinical work now than I did. I do 40% of the clinical work now that I did when I first started. But that's a balance I like, and that took me time to kind of figure out and get to that point. Coming out of residency, obviously I was much younger, much more energetic. So I, had the energy to see patients every week on, week off. After I did that for a few years, like those weeks off, I was tired. Like I was like, I needed a few days to recover. And before I knew it, by the time I recovered, I was back at work. So I was like, oh, I'm not enjoying this as much. As much as I loved the patient care part, it was just mentally taxing for me. So finding those kind of other time fillers, whether it's academics, administration, helps to kind of alleviate that clinical burden a little bit.
Yeah, I think it's really cool to see how you were able to kind of figure it out as you went, and kind of land where you're happy with where you are. So,
Yeah.
a little bit backtrack. You mentioned there are a number of subspecialties that you can do with a fellowship after residency. Um, do you always have to do internal medicine as a residency first? Are there programs that like allow you to directly go into, let's say, cardiology or something?
Yeah, for internal medicine based subspecialties like cardiology, GI, endocrine, all the ones we talked about earlier, there's like 30 of them. You have to do internal medicine residency first. So yeah, you have to do those first 3 years of internal medicine. So everyone gets that base foundation training, and then you go into a subspecialty after that.
Okay, gotcha. So we just got a question in the chat, and that kind of leads us to the topic I wanted to touch up on next. So you mentioned that you had a number of challenges, kind of getting to where you are right now. Maybe you deviated from a more traditional path. Do you mind going over some of the challenges or difficulties you faced, and then your general takeaway from each of those?
Yeah, sure. I think just going from undergrad to medical school, I think I really didn't have good understanding of the application that I needed. The grades that I needed, the GPA, the research, and I wish I could give research. I'm a kind of advice on what you guys need now. This was quite a while ago, so almost 20. It's been almost 20 years now. Uh, so with that, I think yeah. I didn't have a great understanding of the work that it took to really get good grades, to understand the topics, the undergraduate topics. And my GPA wasn't stellar. It was an average GPA is what I had, and not competitive enough to get into medical schools in the United States at the time. So and then I had an MCAT, which I did fine in the MCAT. So I could take tests, like that, but I think I just didn't put the emphasis and the time needed to really um, to be successful in undergrad. And I didn't really understand studying. So I came out of high school, even just if you go all the way back to high school, I came out of high school, I was able to make really good grades without really knowing or needing to study that much. And then I kind of took those bad habits that I had into undergrad, and that's where it caught up to me. And so I got to the point where it was like, I finally started making good grades, grades good enough for medical school in the US around my junior year of college. So my first 2 years didn't do so great. And unfortunately, it's too late. And as I was entering my fourth year, as my GPA improved, I had a choice to make at that point. And so my advisor at the time, so I finally got an advisor, way too late. So get an advisor early, but I got an advisor, and my advisor told me, take an extra year. You're making great grades right now. Take an extra year, take some post baccalaureate classes, boost that GPA, and reapply in the future year. So that was kind of the point where I was like, okay, well, I have a couple options here. And at that time, the option was, okay, stay another year. And at that point, I knew I wanted to do medical school. I figured it out. I figured out how to make good grades. I figured out how to study. So just do another year and then apply. Um, or I could try to get into a non-traditional route, which would be either an osteopathic medical school in the U.S., DO, which is becoming far more common now than it was then. There was a lot of more uncertainty around that path then, and or going to like a international or foreign medical school. So I did a little research in that space, and kind of on my own, even asked my advisor to look into it for me. And ultimately, my decision at that time, I don't know if it was the right decision or not, but the decision that I made was, like, I know I want to be a doctor. I'm ready for it. I feel good now, like where I'm at. I think I can make, I figured out how to study, so I don't think those struggles that I had my first 2 years of undergrad are going to follow me, because I've hopefully learned from those. So I made the option of, let's just start medical school. I didn't know much about osteopathic or the DO degree, so I wanted to have the MD degree. So I opted to go to a foreign medical college, foreign medical school, and I chose one that the basic sciences was a little accelerated, so it was finished in a year and a half instead of 2 years. And then all your clinical work still occurred in the United States, so I was able to come back to the States and do my clinical work there. So that was, I guess, my first kind of struggle in this path towards becoming a doctor, and the decision I made. And was there a follow up on that question, or was there something else? It's still hard for me to talk about. This is like, it's not easy to talk about that, but yeah.
I guess what is your biggest takeaway kind of that applies to any other challenges that someone might have?
Yeah, yeah. I mean, I think if you're struggling, and my what I wished I had learned at that time is like, look, my grades weren't good at the beginning, and to identify that and try actually do meaningful, purposeful things to, whether it's student success programs, some study resources, finding mentors and advisors. I did none of those things. I just went lone wolf and tried to figure it out myself, and I failed. I failed at it because I thought I could just do it. So if you are struggling, do not be embarrassed by it. I thought it was like a stigma, and culturally it felt like a stigma to me as well, coming from in kind of an Indian background, and I didn't want to, I almost tried to not even tell my parents about it. So there was just a lot of pressure that I had put on myself, and I was like, I'm just going to power through this and figure it out and fix it myself. And that was the pressure I put on myself. When I did that, I kind of added more pressure, and then continued, it just made it harder for me. So I'd wished I'd asked for help earlier on, help on how to study, because I didn't know how to study, help on kind of career paths and having an advisor and mentor. And I think if I had done those things, I could have figured it out earlier. Eventually, I think I figured it out. Eventually, I did, and things are going okay. But those were a couple of stressful years of, am I going to become a doctor? Should I choose a different career path? Uh, how do I even do all this? And I think that that could have all been. I didn't need any of that, and none of you need that either. So I think really reach out to advisors, mentors, look for resources. It's all out there to kind of help you, and try to catch it early. If you have one bad grade, take that seriously. Take that one bad grade and try to figure out why that happened and try to learn from it and grow from it, which I didn't do.
Great. Thank you so much for sharing. Now we could kind of transition to a more fun topic. So now that you're here,
Yeah.
how do you balance work and life, and how did you get into the hobbies that you're currently interested in or pursue right now?
Yeah, yeah. So I think one thing I always kind of think about is, when I have an option, when I have a choice, what choice do I make? Do I make a choice to, get on the computer and do charting or do something work related, or do I make a choice to, um, spend time with the family or go out to dinner or book a trip somewhere or travel or whatever, or find a hobby? And I think the choice I've started to make more and more often, and I learned this in residency, was to really choose the thing. Well, choose what you value. So figure out what you value. And I realized my number one value wasn't the work part of it. I enjoy it, I love it, but it wasn't my number one. And my number one ended up being hanging out with my kids and my spouse. And I think that's what I ultimately valued. And I think just setting that foundation makes every decision I make, whether it's a career choice, a daily choice, anything at all, very, very easy. And it starts even like in residency. So like as a resident, your intern year as a resident, no matter what specialty you go into, not even internal medicine, any specialty at all, is really, really hard. That's where you're potentially working 80 hours a week. It's very stressful. You have very little time for anything kind of fun or, meaningful outside of work. And that's just the way residency is. But I made a choice when I had a kid, especially too, that I didn't want to bring any of my work home. That was the one choice I made as an intern, my first year as residency. I don't want to ever bring work home. So I made sure that the day when I would go into work in the morning, I get all my stuff done, get all my notes done. It forced me to become more efficient, through patient care, getting my notes done, all my tasks done, check boxes, whatever your system is. That was my time where I built a system on how to be efficient. And the purpose of that is I wanted to come home and not be connected at all to the hospital. I wanted to be home and be present, in that moment. And as soon as I started doing that, kind of my habits followed along. Where like when I'm at work, I'm at work. I do the best I can. I don't get distracted. I can stay focused over there. But the second I walk out, I'm out. And my leadership team, they all know it too. So they know, like, it's very rare that they don't, they'll text me about random things after hours, but I don't answer emails. I don't even look at my emails. If something comes at work related, unless an emergency, I'm not even looking at it. So that's kind of my, at least, foundation of, like, kind of how do I balance my work and personal life? Because I don't think, we talk about work life balance. I don't even think that that's such a, that term itself. I don't know if I truly believe in. I think you have to find purpose in both spaces. There's work, and you have to find purpose and meaning in it, and then there's your life, your personal life, and you got to find purpose in that too. You're always going to be out of balance. I think that you're always going to kind of be a little bit out of balance, but as long as you're finding meaning in both spaces, I think that's the goal. Um, yeah, and then hobbies, I think as a kid, we traveled a lot. My parents traveled a lot, so I think that was a basic, just kind of learning about different people and different cultures is something that was important, and it's something that I want to share with my family as well. So if you, Sean, I know you follow me on Instagram. You see me like traveling quite a bit, so and I love sharing that too. So that's a big part of what we like to do. I was able to get some, okay, so we can talk about flying real quick too. Up until 2 years ago, after my first kid was born, I never had a problem with flying. I love flying. Even when there's turbulence and stuff, I was like, oh, it felt like a roller coaster ride. I was loving it, right? But about 13 years ago, after my first kid was born, for some reason, turbulence and planes started freaking me out. Like I'll be sweating, screaming. My spouse would be next to me. I'd grab her thigh and she'd be like, "Yo, bro, you need to chill." And so like I just was getting really anxious on airplanes, which I didn't know where it came from. Maybe because once I had a kid, I realized I didn't want to die. I don't know what it was, but whatever it was, it wasn't healthy for anyone. So last year, or a little over a year ago, I was like, all right, how do I face this fear? So I decided, let's learn how to fly a plane. And so I went through pilot lessons and flying lessons. We have an airport 10 minutes, a little regional airport 10 minutes from here. And they do lessons in these small Cessnas, these little four-seat planes. And guess what? Those planes shake when you're in the air. And after the first lesson, like they let you take off on the very first lesson. um, I came back and my shirt was just drenched. I was like, I didn't even realize, but I was like, completely drenched. It was disgusting because I was freaking out so much. But after the next few, you just kind of get used to it, and then you realize, wow, these planes are actually, and these are janky planes that I was flying. Like these weren't the nice planes that are these commercial planes. These were like really old, like 1960s ratchet planes, and they were, you're shaking the engine. You can feel it, you can hear it, and once you like experience turbulence in those and you get used to it, like commercial planes now feel like they're so smooth. So, um, got my private pilot's license, which is really cool. The goal of that was to be able to travel. I haven't gotten to that point yet. We went to Charleston one time with the family, but also faced the fear of flying. And I think it's now when I go on commercial flights are cool. So
What's the next big goal or next big step with flying?
with flying, yeah. So when you get your pilot's license, the first thing you learn is it's called visual flight rules, VFR. So you learn how to essentially fly on your own in overall clear weather, mildly cloudy weather. What I'm not allowed to do right now is go be above the clouds, and I can't go into like storms or any other like rain weather or anything like that. It has to be pretty clear. So that's my current license. The next step after your visual flight rule license is called instrument flight training, or IFR. An instrument is where, I mean, I did a little bit of training. It's required just in case something goes wrong. But if you essentially completely lose visuals because of cloudy weather, fog, rain, anything at all, and you can't see anything out the window, you have to look at your instruments only, your altitude, your speed, your pitch, and that's all you're using to fly. You're using your instruments only to fly, and you can't see anything outside your windows. So that's the next step is instrument. With that training, you can go above the clouds as well.
And are there any, I guess, like dream destinations you really want to fly to once you've gotten all the proper training?
That's a good question. I don't know. I haven't really thought about that. I guess, I mean, I don't know. I just like the idea of just being able to fly anywhere, anytime. Like we have like family in Nashville, and like just leave in the morning, go have dinner out there, and then come back in the evening. Like things like that. That just they're so ridiculous, but like being able to do something like that just sounds cool. Or like, hey, I want to go to a Broadway show in New York. Okay, let's just go today, and I'll be back tomorrow or something. So being able to do stuff like that without having to like look for tickets and like because once you have your pilot's license, like you literally can walk onto an airport tarmac. You rent a plane, or if you have your own plane, you can obviously buy a plane, but you can rent a plane, and you just talk to air traffic control, and you just take off. There's no security. There's nothing. You just have your own like private access to an airport, and then you have your private access when you land wherever you land. And there's just no security, nothing, no check-in. You just literally just go and take off, like getting in your car and driving. So I don't have a specific location, but just being able to do stuff like that, I think, is what I want to do.
Yeah, you easily have the coolest hobby we've ever had a physician have on this platform. So, all right. So right before we go into the case study stuff, we have a couple questions in the chat. So we could knock two with one question. How did you get into internal medicine? Was there like an event that like triggered your inspiration to pursue internal medicine?
Yeah, no, I mean, when I was in so when you're in medical school is when you have to choose your residency, and typically you have to choose it by your kind of your third going into your fourth year of medical school is when you have to choose. So I kind of just knew I liked. I didn't like the OR. So the first thing you have to decide is like, do you like the operating room or not? Do you like getting up early in the morning and cutting people open? And that just wasn't my thing, I guess. Just the early morning operating room. It was fun in the moment, but it was not something I could see myself doing lifelong. But I did like talking to people. I did like getting to know them, and my favorite part of the surgery rotation was not the surgeries, but actually taking care of the patients in the hospital after their surgeries and talking to them. So then I realized I like primary care. So it really came down to, for me, family medicine or internal medicine. And both were good options, but ultimately for me, internal medicine just had more potential career opportunities with all the subspecialties, all the fellowships, and that's when I picked internal medicine. There wasn't any like crystallizing moment. It was kind of a gradual process of realizing I didn't like surgery, knock those out, realizing I like primary care, and then wanting to keep as many options open is kind of how I got to internal medicine.
And how about your decision to pursue medicine in general? Was there any event or any inspiration for that?
Like, you mean just like internal medicine in general, or
Or
instead
to
of doing
pursue
subspecialty?
medicine in general?
Oh,
So
medicine. I'm
like,
sorry, medicine in general. So, yeah, sorry, my mind is like in a different place. Yeah, yeah, medicine in general. Yeah, and I don't know. I mean, when I think we all have like family, personal things that kind of have happened, and sometimes that's an inspiration. I don't know if that was for me, but my dad had a heart attack at a pretty young age. I was only like 5 years old when it happened, and I remember like following the ambulance to the hospital, and my mom crying in the car, and being in the hospital with him, and just seeing how nurses and doctors took care of him and talked to us. So that was like my first, I guess, exposure to just healthcare in general. And I guess from then, just going through, as a kid, going through school, elementary, middle, high school, although, just science was a topic that I think I just connected with, and I was always my favorite subject. So that's kind of how I was getting into medicine. As a high schooler, I started doing some of those pre medical like clubs and stuff like that. So I was at least like started shadowing a little bit as well, and getting to meet doctors as a high school student. So that's probably what helped me get into medicine in the first place.
all right, next question is let's see. Maybe if you want to very briefly talk about what the applicant or what the admission process looks like for med school versus residency. You don't necessarily need to go into the technical details, but how does that process differ?
Yeah, I can probably speak a little bit to the med school. Obviously, better to the residency side. That's where I'm at. But the med school side, I'll speak briefly. I think, ultimately, things like GPA and your MCAT score and research and publications. I think that stuff does matter quite a bit. The numbers matter quite a bit for medical school. I think having some clinical experience is also helpful. So whether it's some kind of shadowing experience, but getting to know physicians, um, getting to work with them, or be in their office or the hospital, things like that, I think can be helpful as well. You want to get letters of recommendation ultimately from research advisors, from physician advisors as well. Um, but it's I know I don't have as much knowledge on the medical school side, but that's kind of I think it's pretty typical. Grades and scores really are quite important. And as you go through medical school and get into residency, it really depends on which residency you're going into. Some residencies are far more competitive than others, and you have to be aware of that when you're going through medical school, because you really want to make sure that you're building an application that's competitive enough for the residency that you're applying for. Internal medicine is a moderate competitiveness overall, and even within internal medicine, some programs are far more competitive than others. So there's a lot of variability there. Sorry, let me put my phone in here. And then, there's specialties like orthopedic surgery or dermatology that are supremely competitive. So, a neurosurgery. So, those are ones that require higher. So, when you're in residency, after medical school, when you get into residency, you'll be taking USMLE exams. And those are basically step exams or board exams that you take. So, scores on those tests, your step two is your main one that has a score is very important for the more competitive specialties. You want to make sure you score really well on that particular exam, and then having a lot of research, similarly to going to medical school, but a little more research that's focused in the specialty that you're going into is important. So when you're in medical school, if you're really thinking about these competitive specialties like dermatology or orthopedic surgery, you want to do research projects that are in those spaces. So don't just do anything, do things that are in those spaces. and then having advisors and having clinical experience so that you can have strong letters of recommendation as well are important for residency application.
Cool. So I think we'll at this point move on to case study, and we'll spend about maybe 10 to 15 minutes on that. Do you want to screen share? Is that okay?
Yes, yeah, I'll screen share here.
Okay. So if anyone else does have any other questions, you can actually email the PhysiLink Gmail. The way this works is at the end of every month, we'll kind of take all the questions that we've received, and then we'll go to Dr. Rao and have him answer those questions for us, and then we'll release those answers. If you do want to kind of be in the know of when he's releasing those answers and then future webinars as well, we have multiple physicians that are featured every single month. You can subscribe to our newsletter and join the initiative, and you'll get like a newsletter once a week, just notifying you of questions and answers, other webinars, other opportunities as well. So I've dropped both of those in the chat. Feel free to click on them and put your non-school email for the subscribing to the newsletter.
All right. Well, so I'll share like a typical case that we see as a classic case that we see all the time in the hospital on an internal medicine case. So this is a patient that will be admitted typically to the emergency room. I'll kind of talk you through how they present. There's a lot of acronyms on here. So any of you, if you see something, I'm going to try to talk and break it down a little bit. I don't know if you can see my mouse, but I will try to break things down. But if you have any questions, please interrupt anytime. I can't see the chat right now, so you can just unmute yourself and ask any questions that you have. There's a little audio thing on here. I don't know if it'll work, but we'll give it a shot. All right. So here's the introduction. This is a 62-year-old man, so this is a classic internal medicine case with a history of HFrEF. So HFrEF, this is heart failure with reduced ejection fraction. So this is a type of heart failure where you see that EF next to 25% ejection fraction. Ejection fraction is a measurement of how your heart, how effectively it pumps blood. Normal heart, any of us here is, about at least 55 to about 70% is a normal ejection fraction. And you see that this particular gentleman is at 25%. So his heart is pumping at a much lower rate or lower effectiveness than is normal. So he presents with worsening shortness of breath for 3 days. So symptoms, orthopnea. So orthopnea means that he's not able to lie flat anymore. So think about just when you go to bed at night and you're sleeping and lying down, you can normally lie flat. This particular patient can no longer lie flat. He's using 3 pillows to kind of prop himself up. He's noticed increased leg swelling and fatigue. And here is vital signs. So his temperature is normal at 98.6 degrees. His heart rate is fast, 110. Blood pressure is 160 over 90. Oxygen saturation is 86% on room air, RA's room air. And then respiratory rate is 26. So I guess I have a question for you guys. This is my teaching side, so I'll ask a little question. So what are you concerned about? Just seeing this patient presentation and maybe some of the symptoms or vital signs? What kind of seems worrisome? Anyone can answer.
All of the vitals except for the temperature.
Yeah, you're right. So the temperature is normal, but the heart rate looks a little up. The blood pressure is a little bit high. Do y'all know the kind of what normal blood pressure is typically?
(120/80).
Yeah, 120 over 80. Yeah. So even less than 130 over 80 is probably okay as well. So certainly the blood pressure is high here, which tells us that he's probably under a little bit of stress. His body's under stress. Oxygen saturation is 86%. What do you want that oxygen saturation to be? What's normal?
Above 95%.
Yeah. So you're exactly right. Typically, for a normal person above 95%, patients that have lung disease above 89 or 90% is usually okay as well. So certainly this is lower than normal. Room air just means that he's breathing room air. He doesn't have any supplemental oxygen. And his respiratory rate is 26. That's fast. Typically, we usually breathe about 14 to 18 times per minute, and he's breathing 26 times per minute. So clearly he's working a little bit faster. Okay. All right. What about the kind of orthopnea, leg swelling? Any concerns there?
I have a question. What is orthopnea? Like you mentioned, he can't lie down, but what happens if he does?
Yeah, so he'll feel like he's drowning, essentially. He'll feel very, very short of breath. He won't be able to breathe. So just sitting up allows him to breathe a lot more easily. Good question. So that's a concern, right? Certainly, like, him not even be able to lie flat is worrisome. So yeah, so there's several things here that are going on that are worrisome, and not really sure yet what's causing it. And that's really the point of internal medicine. We have this patient that we know has a weak heart, and now he's not able to lie flat on his back anymore. He's got swelling in his legs, which is not normal. We don't, we sh- None of us should really have swelling on our legs. And then, like y'all noticed as well, as other than his temperature, his vital signs are not. I'm not comfortable with any of those vital signs. Okay, I think it's a good start. So here's kind of a physical exam. And so this is the way we write it out is, so we talked to the patient already. We did our history. That's what we got. He's not able to lie flat. He's more short of breath. Now we're going to examine him. So when we look at him, this general is just kind of looking at him. Dyspneic. Dyspneic means difficulty breathing. He looks like he's working hard to breathe. He's not breathing normally. He's using accessory muscles. So accessory muscles, when we're breathing, when someone's breathing, you don't notice them breathing, right? That's normal. It's natural. But if you see someone doing this, really raising their chest up, or they sometimes will breathe and they're really contracting their neck muscles. They're using extra muscles or accessory muscles. Their belly, they'll start to really huff and puff with their belly, because they're having to work harder to breathe. They're having to use different muscles around their body to help expand their chest. So that is not a good finding. Someone's struggling at this moment to breathe. So lungs, bibasilar crackles. I have audio. I don't know if it'll work, but I'll try to play it for y'all here. Normally when you hear lungs, you hear this normal, and that's when you're listening with your stethoscope. Crackles is a term that essentially is kind of like, think about it like Velcro. If you're separating Velcro, you have that kind of rough sound, and that's what crackles are. So you're not hearing that smooth noise. It's a little rougher sounding. And then when you put the stethoscope on the patient's heart, I wish I had my stethoscope here, but stethoscope on the patient's heart, tachycardic. Tachycardic means the heart rate's fast, so it's faster than normal. S3 is an extra heart sound, so there's an extra heart sound that's abnormal. And then extremities, so the lower legs, there's 2+ pitting edema to the mid shin, so that essentially means there's swelling. And when you push your thumb onto their leg, it leaves an imprint because of that swelling. So we talked about that leg swelling that the patient was complaining about when he came in. On your exam, you'll appreciate edema, and it's gone all the way up to his mid shin, so close to his knees. So let me see if I can get this volume to work here. You all hear that? You all hear that? You all hear that? So that's normal. Okay. Now I want you to listen to what abnormal lung sounds like, the crackles.
I don't think we could hear anything.
Oh, you can't hear that? Ah, darn. Okay. Well, essentially it sounds like that Velcro separating. So that's essentially tells us that that's a sound of crackles. All right. And then this is a picture of pitting edema. Let's see if I can kind of show what that looks like here. So you see that kind of left an imprint when you push on the foot there, it leaves that imprint. And that swelling, in a heart failure patient can potentially, depending on how bad it is, can go all the way up the knee, up the thigh, even into their belly or their abdomen. You can have where you push the thumb and it kind of leaves that imprint. So that's called pitting edema because it leaves a pit when you push down on it. Okay. So that's what we have so far on our history and physical exam. So we're still trying to figure out, okay, clearly this patient is sick, not breathing well, breathing fast, using accessory muscles. There's swelling on the leg. There's pitting edema. So all these things are just concerning, and he obviously doesn't look well either. So we're really worried about him and whether we can kind of pull him through this and figure out what's going on. But ultimately, it comes down to making a diagnosis. So here's our initial workup. There's a BNP, which is a particular lab. It's brain natriuretic peptide, which is an enzyme that's released by the heart. It is high, 1200, so that's a high number. Troponin is another enzyme that's released by the heart. That's normal, so not elevated. Creatinine, which is a blood test that we do to evaluate kidney function, looks like it's high, right? Normal is around 1, and he's at 1.5. And sodium, his sodium is low at 132. Normal is like 135 to 145. So sodium's a little bit low. And we get a chest x-ray, all right? And so the chest x-ray shows, it's described as pulmonary edema, large heart and large cardiac silhouette, and then a right greater than left pleural effusion. So if you look at these chest x-rays here, if we start on the left, that's your normal chest x-ray, okay? In the middle, I wish my mouse was working, but the middle, you can see the heart shadow or border, the cardiac silhouette, and then both sides where you see the ribs, that black space is the lung space. Okay, and you want it to look just like that. You want it to be kind of that black space because that tells us that the lungs are normally aerated. Now, as we move to the right, the next chest X-ray and the one after that, what I want y'all to kind of hone in on is that black space where the lungs are. You see that it's not as there's kind of this more whitish area, and there's worsening of that whitish area and kind of haziness in that lung space as you move to the right of the screen. And as you get all the way to the right, you see that it's almost all white out, right? The lungs are almost all whited out. So normal lung all the way on the left, where you have, kind of that, you can see the rib shadows very well, and you can see the lungs should appear dark or black like that. And all the way on the right, you have all that white. And what is classically creates that whitish look on chest x-ray is fluid. So anytime there's inflammation or fluid in the lungs, it's going to look more and more white. And so our patient's chest x-ray is probably very similar to the one on the far right, where it looks like there's a bunch of fluid. Okay, so that's our theory right now. When I see a chest x-ray like this, which is usually the first test that's done when a patient comes in short of breath to the emergency department, they're going to get a chest x-ray. What does that chest x-ray look? How does it compare to a previous chest x-ray that this patient has had? So you want to be able to compare the chest x-rays and ultimately try to make a read on it. So our theory right now is we have this heart failure patient coming in sick, short of breath, swelling, and looks like on that chest x-ray that patient might have fluid on both his lungs, and that may be contributing to his inability to lie flat on a bed or using accessory muscles to breathe. Okay, so far so good. Any questions about any of this? All right. So this is something that's new to my practice, new-ish. Ultrasound is something that, especially for internists, or I think it's become such an amazing tool, and it's something that we don't have to wait on a radiologist. We can do it bedside. And I brought my ultrasound. This is what I use. So this is a butterfly ultrasound. It literally plugs into my phone. I had to have some water gel, and it's able to give me really good images. So what I'm doing is with this patient, I'm looking right up here with this ultrasound connected to my phone, and I'm looking at exactly seeing what I'm seeing. So if you look at the left side of the screen here, I'm going to play this. The left side of the screen is what I'm seeing when I'm putting my ultrasound right up here, and the far left side, you see those like horizontal white lines where it says pleural line, rib shadows. Those horizontal white lines are what we call A lines. Those are normal aerated lungs. So if I did this ultrasound on any of you or myself, that left side of the screen is what we should be seeing, meaning our lungs don't have fluid in them, normal air in the lungs. Now, if you look at that still on the left picture, the picture on the left, you see it almost looks like a laser show, like this kind of shooting down. I don't know if it's projecting very well. But anytime you have those vertical lines on this ultrasound, that indicates inflammation that could be happening from like an infection, like pneumonia, or fluid that's built up. So we already have this theory, right, from the chest X-ray that we have fluid building up on the lungs from this heart failure patient. That's probably contributing to his shortness of breath. And now we have this ultrasound with B lines. So you see the one with B lines. Those are the vertical lines, and that tells us that there's fluid on the lungs. So this has been an incredible tool to be able to evaluate your patient and see right away what the answer is. Sometimes you have a patient that's already hospitalized and you don't have time for a chest X-ray. They're crashing right now. They're crashing. You don't have time to send them down to the radiology suite to get an X-ray done. So I pulled out my ultrasound while the patient is unstable, look and see what I have. If I see those B lines, I know exactly what I'm dealing with, and I know how to treat it in that moment. And instead of wasting time trying to get another image or trying to get more tests, I already know the answer bedside. So that's what I learned. So we learned that this patient has B lines and fluid. Now the picture on the right is that's a right upper quadrant ultrasound. So you can see that anytime so I'm going to take this ultrasound, I'm going to put it right under my armpit, up to the level of the diaphragm. You can do this on both either side. This could be your right or left side. So with this, typically this is the most likely a right-sided one. You see that's kind of hard to describe. I wish I could point it out to y'all, but like there's that black space, black space right above. That's the liver over there. But right above the liver, there's a black space on the left side of that picture. That black space is fluid. So there's fluid not only in the lungs, which is what we're seeing here with those vertical lines, but there's fluid outside the lung as well. That's called a pleural effusion, and that's that black space that you're seeing. If you can kind of look on that same picture on the right side, as you look towards the left, you see this thing kind of wobbling around. That's actually the lung. So that's the lung kind of floating around in fluid. It is not normal to be able to see the lung that clearly with an ultrasound. But when you have fluid around it, it creates an acoustic window and you're able to see the lung ecotexture a lot more clearly. So if you're seeing the lung normally with an ultrasound, that tells you that there's fluid or something else wrong. You should not be able to see the lung that clearly. So right now, we already have kind of an answer. We're getting towards the answer. This gentleman's short of breath, very, very sick. He's going to need extra oxygen. And it looks like he has fluid both in his lungs and around his lungs. That's really restricting his ability to breathe well. Any questions about that? All right, move on. So I'm like, all right, let's take a look at his heart. We already know he has heart failure, but what does that look like? And I want to show you all what heart failure looks like on ultrasound. So what I'm going to do is take the same ultrasound and put it right here on his chest. There's multiple views that you can get of the heart. This particular view is called a peristernal short axis view. It's a nice cross section of the left ventricle. So if you know your heart's anatomy, you have the atria, which are your top chambers, and your ventricle, which are lower chambers. Your left ventricle is the final chamber before blood is pumped out to the rest of your body. And that's a chamber that if you have reduced ejection fraction, like our gentleman, pumps more weakly. And if you have a weaker pump, ultimately blood that should be going forward goes backward, and it goes backward into your lungs. So I'll show you what it looks like. I'll show kind of both sides here. So the screen on the left, that's squeezing. I don't know how smoothly y'all are able to see it, but that is a normal functioning heart. So, if we talked about a normal ejection fraction around 55 to 70%, that's probably a 55% ejection fraction right there on the left side of the screen. Now I want you to compare that to the right side, which is probably closer to our patient, 25%. And really focus your eyes not necessarily on the inside, but on the outside of the heart. So the outer circle here of the heart, and that's where you can tell the difference in squeeze. And hopefully you can see that the squeeze on the right side, where there's heart failure, is much weaker than the one on the left. So not only were we able to take the ultrasound and look at the lungs to see fluid inside and outside the lungs, we also looked at the heart and saw that the heart is weaker. And it's been nice. This particular patient, we already knew that answer. We knew he had heart failure. But there's some patients that come in and for the first time, and they're coming in short of breath and have never been told they had heart failure. And then simply taking this ultrasound and putting it on them you can see it right away, and you'll be able to at least get a general sense of their heart function. All right, y'all, I'm nerding out on this, so please interrupt me anytime about this. All right. So ultimately, we got all this data, right? And that's what internists do. You get all this data. The most important data, which is history, and we'll talk about that more. You have the physical exam. So we examined him. We saw a fluid with pitting edema. We listened to his lungs, heard the crackles, and then we got the chest X-ray. So we got some imaging. We got some labs, right? That BNP that was elevated. His creatinine, his kidney function is a little bit worse. And then we did the ultrasound. So we had to put all those things together and come to a diagnosis, and that's what internal medicine is about. It's really, if you like puzzles, and I love puzzles growing up, but if you love like breaking puzzles and working on puzzles, that's what internal medicine is. You're gonna have all these pieces of information, all these things that we just talked about were all different puzzles. Can you put those puzzles together and make a diagnosis out of it? And for us, this is the diagnosis. It's a fancy term. It says acute decompensated heart failure with reduced ejection fraction, with hypoxemia, and a right greater than left pleural effusion. So putting all that together, the word acute decompensated, that means that this patient has normally controlled heart failure, but in this moment it is not controlled. It is decompensated. And with hypoxemia just means low oxygen levels. So his oxygen level we saw was 86%. And he had that pleural effusion, that fluid around his lungs as well. And when it's around the lungs, it's called a pleural effusion. When it's within the lungs, it's called pulmonary edema. So he has that as well. So yeah, that's kind of a basic case right there of heart failure, and taking all those pieces of data, bringing it together, and then making a diagnosis. And all that, even though broken down slowly, sometimes has to happen very fast. You have a patient that's crashing, about to code, potentially the heart's about to stop or they're about to stop breathing. You want to be able to identify these things, this diagnosis quickly and treat it. So let's see how we kind of treat it. There's different things you have to think about, but respiratory support. So, we saw that patient's oxygen level was low when he came into the hospital. So you have to think about different forms of oxygen. The ones you've commonly seen is called nasal cannula, just those things that go right into your nose and hook up to an oxygen tank or to oxygen against the wall. There's limitations to how much oxygen can actually flow through your nose, but that's one way. You can do oxygen through a mask, where you have your ability to deliver a little bit more oxygen. You also have pressurized ventilation masks, which gives you the opportunity to not only deliver oxygen but pressure as well. So, patients that are really not breathing well, that's an option. And ultimately, if they're not able to breathe at all, or if they're struggling with all these, or they're not options, you may have to intubate a patient, where you actually put a breathing tube into their mouth, through their throat, into their kind of airway, and hook them up to a ventilator and provide ventilator support that way. So you kind of have to, every patient that comes in with shortness of breath or low oxygen levels, you have to consider all those types of oxygen to decide which one is best for that particular patient. For our patient, we know that he has fluid, right? Fluid is what was causing the shortness of breath on his lungs, around his lungs. So we want to get some of that fluid off. So we use a medication called a diuretic. Diuretic is a class of medications that help to get extra fluid off your body, and ultimately have the patient urinate that extra fluid out. The particular medication we pick it's a very classic one called IV furosemide. IV because it's delivered through the veins, and furosemide is the name of the medication. It's also known as Lasix, but it's a common diuretic option that's available. So a patient like this that came in, that's the first thing I would do. As if you had the opportunity, make sure he has oxygen, get his oxygen level back up to normal, and get him an IV diuretic like furosemide as quickly as possible, so that you can start to diurese and get rid of some of this fluid. You can also do a thoracentesis, which is, he had fluid around his lung, right? So you can actually physically drain the fluid around his lung. And I have a video there, but instead of the video, I'll get you guys can look at that video on your own. I'm happy to share that. Let's see if I can turn this screen here. Y'all see my screen? I don't know if you can see my video here, but this is a thoracentesis kit. So this is a classic thoracentesis kit that we have in the hospital. Are you able to see that? Chime, can you
Yes,
guys
we
hear
can
me?
see it.
Okay, perfect. All right. So I'll just open the kitchen, try to figure what it looks like. So this is all sterile normally. So I would normally have sterile gloves on. I don't have them on right now, but just as first showing y'all. All right. So whenever you open these kits, you got to identify everything that you need in here. But essentially, what you need, I'm gonna try to do this one-handed because I'm holding a phone. It's gonna be really hard. But you first want to sterilize the patient. So you typically have something like chloroprep or iodine to sterilize that skin. And you will go in through the back. So you have them lean over, you expose their back because you're essentially going to put a needle through their back to drain fluid off. This is a drape. So this is just, this goes just right over the patient and they'll, over the site that you want to go. You saw the ultrasound earlier. We'll use that ultrasound to identify the space. We'll go right over the spot where we have that largest dark space. Then that identifies where the largest space of fluid is. It can be a painful procedure, right? You're poking around, so there's lidocaine here. So I'm gonna take some lidocaine. I'm gonna draw it up in a syringe. There's a little needle here, and I'm gonna inject it right at the site that I'm going to be removing fluid from. So that is to numb up that area. I want to numb that area up as much as possible so that way the patient feels as minimal pain as possible. Okay. And you take the scalpel right here and you poke in that same space. And at this point, there's lidocaine, so the patient should not feel sharp pain. And you do this to really create a tract so that way you can access the pleural space. And this is the main device that we want to use. You can see there's a syringe here, and then there's a catheter. This white part is the catheter. And then right at the end, you'll see the needle. Okay. So what I'll do is that same space that we already gave lidocaine, we numbed it up, space that we see the fluid is highest, we inject this needle into that space through the skin, past the ribs, into that lung space, the pleural space. And as soon as I'm in that space where the fluid is, I'll be keeping negative pressure on my syringe right here I'll be pulling back like this. And as soon as I pull back, I'll see fluid in the syringe. And once I see fluid, I know that I'm in the right space. And at that point, I will push this catheter all the way into the patient and take the needle out. And at that point, this plastic catheter will be inside the patient's chest through the back. And I can hook it up to a drainage like this, like a drainage bag. And I can drain out all the fluid, or as much as I can in that moment to take that fluid off. And you'll see here, there's also lab containers. I don't know if you can see them. These little lab specimen containers. So if I didn't know the cause of the fluid building up, it's not just heart failure. Fluid like this can build up from blood clots, from infection, from cancer. And so sometimes we don't know the reason why that fluid built up on the lungs. So we'll fill up these little tubes and we'll send them to the lab and run some studies on that fluid to figure out what exactly it is and what caused it. So not only that, so there's kind of two terms for this. It's called a diagnostic. There's thoracentesis, when you take the fluid off to try to learn what caused it. Diagnostic, right? You try to diagnose the cause of that fluid. But then it's also therapeutic. Therapeutic meaning you're going to make the patient feel a lot better. If you I've taken off more than 2 of these bags off someone's lung before. Once you take that off, I mean, you have immediate relief, right? The lung re-expands and the patient's able to breathe a lot better. So it's a diagnostic because to diagnose, and it's also a therapeutic therapy. You make the patient feel better procedure. And that's pretty much it on that procedure. Let me turn it back around here. All right, let's come back to the talk here. I think I'm pretty much done. Yeah, so improved breathing. Once you gave diuretics, we did that procedure, got fluid off his lungs. His edema, swelling both in his lungs and his legs improves, resolves, and he's discharged home. And specifically with heart failure, there's medications that are proven to um, kind of prevent him from coming back to the hospital, keep fluid from building up in the future, and hopefully have him live a better, longer life as well. So there's specific medications around that. And that's, I think, all I had. So biggest takeaways. So practicing internal medicine, like we talked about, history and physical exam. I think that takes continued practice, continued getting better at it. And Shyam, you asked earlier about like how do you connect with a patient that may not, that you may feel disconnected with or may not believe in what you're doing. And I think that ability to build that trust with the patient is the most important thing. That takes time. It takes time and technique to learn how to actually communicate effectively with your patient. I have the word history there kind of bolded. And the reason is, I think out of everything on here, my opinion is that history is the most important thing. If you can connect with your patient and have them tell their story and exactly what happened and what's been going on, oftentimes you can get to the answer even without all the $1 million workup and all the tests and the ultrasound and all the things that we've done. You can get to the answer just by having a really good kind of connection and communication with the patient. Bringing those labs, imaging, ultrasound, procedures. I love doing procedures. I'm very hands-on. So again, I didn't like the operating room, but I do like doing procedures like this. These are fun. And then coordinating care. Even one thing we didn't really talk about much was even things like social determinants of health. And I think that's such a big part of taking care of patients now. Do they have a home? Do they have food insecurity, transportation insecurity? How do you help patients become successful outside the hospital too? And a lot of that takes a lot of complex care. Do they need to go to a nursing facility to get rehab prior to going home? There's so many things that you have to kind of take into account when you're thinking about what is best for that particular patient. And that's all I had. There's my email address, so y'all can email me anytime. That's our program's Instagram and my Instagram. My Instagram is the first one, Love Curiosity Advocacy, and then our program's Instagram is Prisma. I'm Residency Greenville. Welcome to follow either of us. Mine's more personal with hobbies and travel, but the program one, we'd definitely like to share all the things that our program's doing, or what our resident life is like, what wellness is like. We want to recruit all of you. If you all are interested in internal medicine one day, we want you to come to our program. So, follow us on Instagram and kind of, just stay connected with us. And that's it. I'll, on that note, I'll stop sharing my screen.
All right, thank you so much, Dr. Rao, for sharing your story, your challenges, how you overcame them, and then specifically taking a lot of your time to go over the case, explaining all of the little details. And I've learned a ton, and I'm sure everybody else did. If y'all have any other questions, feel free to either email him, or you could also do it through the PhysiLink Gmail. We'll make sure to get those answers to you as soon as possible. I also encourage you, like I mentioned earlier, to subscribe to the newsletter. Next week, we have a colorectal surgeon that specializes on laparoscopic procedures. So we're looking forward to that. But Dr. Rao, thank you so much. Is there any final words that you have for everyone?
No, I just want to say, like, yeah, really, thanks for having me. I hope this was a good kind of event, and you learned a lot about internal medicine. I really want y'all to feel comfortable coming and reaching out to me by email. And if you want to come to Greenville and just check out our hospital or shadow one of our doctors, there's a lot of opportunities for that. So stay connected. I think and I think venues like this that Shyam is putting together with building these mentorship connections, most important thing. So glad Shyam that you're doing this. Thank you for putting this together. And just let's stay connected, guys.
Dr. Rao is incredible, so definitely reach out. But I'll leave you all with that. Thank you so much. Y'all have a great rest of your day.